Jesteśmy zespołem terapeutów DBT
i opowiadamy o terapii dialektyczno-behawioralnej
z myślą o osobach doświadczających dysregulacji emocjonalnej,
a także ich bliskich, terapeutach i wszystkich, którzy chcą nas posłuchać.
Robimy ten podcast, bo wiemy, że terapia DBT jest skuteczna
i pomaga w zbudowaniu życia wartego przeżycia.
Jeśli uważasz, że to, co robimy, ma sens,
możesz nas wesprzeć za pośrednictwem serwisu Patronite.
www.patronite.pl/kurs na DBT.
No to co? Jedziemy!
Cześć, z tej strony Kaja. Mamy piękny majowy dzień, a ja jestem na konferencji Polskiego Towarzystwa Terapii Poznawczej Behawioralnej w Warszawie, gdzie mam niezwykłą przyjemność porozmawiać z dr Armidą Rubio Frucetti. Armida Frucetti jest zastępczynią dyrektora kliniki ambulatoryjnej 3 East DBT dla młodzieży w szpitalu McLean oraz wykładowczynią na Harvard Medical School w Stanach Zjednoczonych. Swoje doświadczenie opiera na wielu latach pracy oraz superwizji w różnych placówkach klinicznych, gdzie wykorzystuje DBT dla dorosłych i młodzieży. W pracy skupia się na problematyce dzieci przed okresem dojrzewania, na nastolatkach i pracuje również z parami i rodzinami. Oprócz pracy klinicznej, Armida prowadzi badania dotyczące interakcji rodzic-dziecko i rozwoju dysregulacji emocji. Ma też wielkie doświadczenie w prowadzeniu treningu Family Connections oraz badaniu skuteczności tego programu. Ponieważ DBT było tak obecne na tegorocznej konferencji, nie mogliśmy nie skorzystać z okazji i nie zaprosić naszych gości do rozmowy. I to jedna z nich. Zapraszam.
I am very grateful for the opportunity to talk today, almost at the end of CBT conference here in Warsaw. And I do appreciate the fact that dialectic behavioral therapy was so widely discussed here. And we are all very happy to have you here, Armida. I'm really grateful for that. And I'm also very grateful and excited to finally have a conversation about a very important group of patients. My first question is, well, you were talking yesterday about children who may need DBT in their life. Who do you think would benefit from DBT in children and adolescent population the most?
Yeah. So I think, well, first, let me just say I'm delighted to be here, and I'm so happy that the conference had us present and want to support all the amazing work being done in Poland already in DBT. So I appreciate all the work you all are doing. I think with children and adolescents, one of the things that we understand from a DBT perspective is that emotion dysregulation is really the core issue. And I think, initially when DBT started, it really focused on the adult population. And, we see that with the transactional model, we can kind of see that this starts when people are very, very young. Mm-hmm. And the earlier that we can intervene with a child, then it really saves their lives, not only because they may not longer be suicidal, but they can then have a life worth living and a full kind of exposure kind of life, which is good for them. It's good for their families. It's good for society. Mm-hmm. So I think in terms of who do we look for? We look for kids who are demonstrating difficulties with emotion dysregulation. And what that can look like are children who have kind of impulsive behaviors, explosive behaviors, but also those children who seem to shy away from life, who want to spend time in the room all by themselves and don't seem to have any desire to be out in the world. They may be very quiet children, but they're so quiet that they're just almost within themselves. And their parents are maybe worrying like, oh, my child spends all day in their room. What's the matter? They don't seem to have friends the way that other people have friends. They seem excessively shy. And so we want to look for both sides of children who are emotionally dysregulated. I think we're pretty good as professionals in terms of identifying those children who have the more explosive emotion dysregulation. And I'm very concerned that we're missing these kids, the more quiet ones, who they're not causing, quote unquote, any problems in life for teachers.
Yeah, they don't cause riots.
Exactly, exactly. And so we're missing them. Yeah. And then we only find them when finally they do something, like they harm themselves so severely that they require medical attention, or they become hospitalized because they're suicidal, and people are shocked, like, well, wait, I didn't know it was that bad. And that's where I think we really need to focus on how do we find those children.
You are also talking widely about, I would say, two levels of care, in sense of having like primary care, let's say DBT on the front line with some of the interventions, some of the skills for children or adolescents who do not fulfill any diagnosis, and then the second line or the second tier of the patients, right? People who are in this care. And I'm wondering, is DBT universal for these two groups in some sense, or in what sense you would say it is universal?
Yeah. So I think what we'd have to do, so for example, for the children who aren't meeting diagnosis yet and are still displaying some difficulties with emotion dysregulation, I think there are ways, and we have started to modify DBT. DBT is a very comprehensive package. It's kind of like, a huge vaccine series, right? And children who aren't quite meeting criteria and yet are still struggling with emotion regulation, right? I think we have ways that we can modify, and we've begun doing some of that work to modify what are some of the critical components of emotion regulation that those children need, and can we help the children learn how to do it and support the families, because the families are critical. We know that parents of these children are critical in terms of being able to support their child. Oftentimes parents are really trying to support their child. They just don't know how to support this child. Yeah. They may have other children in their home and they think to themselves, my other children are fine. What is it with this one?
Exactly.
And so, if you have kind of multiple children in your household and you're trying to sort that out, I think there are ways that we can kind of modify to kind of like give a quote unquote lower dose to be able to be very targeted in what are those skills. Because oftentimes those children have other skills available, which is fabulous. It's just maybe they're missing one critical component that then if we can stop that there, we could then maybe delay and the child won't have to go into the mental health system, which then is amazing for that child, for that family, and for the mental health system itself.
Of course. You're talking about younger children, and I'm wondering what are the youngest children that can benefit from DBT?
Right. So the youngest children that our program, and we've been collecting data, the youngest child that we had in our program was 7.5 years old. So the KID program that we specifically target this younger population is from 7.5 to 12 years old. And then we have an adolescent program that we've also evaluated that runs from 13 up to age actually 21, because in the United States, the 18 to 21-year-olds are still considered part of the adolescent model.
Okay.
And so, but we've broken it down into those two groups. People have asked me, do you think you could develop DBT to work even with a younger population? I think we can. I think there are unique things that we'd have to think about. Like if you're working with let's say a family, actually a parent came to me yesterday at the conference and asked me about their 5-year-old, because they said, I think this applies to my 5-year-old. What recommendations do you have for me? And so I was able to spend time with that parent. There are differences, of course, of a 5-year-old to an 8-year-old, right? Developmentally, a 5-year-old is even more reliant on parents. And I think there's also, I want to protect childhood as not, I've run into too many children who had been in therapy since age 4.
Over-therapized, right?
They're over-therapized, and I think it gives them the message something's wrong with me. And so I have been considering how would I change change the kid program for that younger program, because I'd actually rather not have those little children meet with a therapist if I can help it. Their parents are there. Parents are amazing. And so I think there are ways that we can kind of modify that. And I think, as I said yesterday, as I get older, my patient population that I'm interested in get younger. So maybe after I turn 60 this year, maybe I'll be focusing on the 5-year-olds.
Okay. I see it as a beautiful perspective for development of DBT in connection with family therapy. Well, development,
Yes.
it is developing already. It's developed. But I see how much of these interventions can happen within the family, not to the child individually.
Exactly.
Yeah.
Exactly.
Which skills do you find the most life-changing for families from your practice?
I would say that for parents, when you have a child that's struggling, as a parent, oftentimes your heart is breaking because your child is struggling and you really want to make it all better. And so for parents, oftentimes it's really about being able to manage their own emotions so that then they can figure out how do they want to help their child. Yeah. Because oftentimes if our own emotions aren't managed, we might kind of panic and start throwing solutions at our kids and not recognizing maybe that's not what they need. Maybe what they need is just for us to hug them and not say anything, or just to sit with them and let them talk. Right. And as parents, we get accustomed to, we got to solve that problem. We got to solve that problem. And so I would say for parents, it's learning, how do I manage my emotion to tolerate being distressed over the fact that my child is really struggling? Because I think that opens up a lot of different avenues. I think for kids, I think it's being able to, and this is transactional, right? Being able to kind of tell my parent and express to my parent, what is it that I want from them? And to recognize that, because oftentimes kids will tell me, I just want to be able to tell my parents something without them trying to fix it.
Yeah, without solving the problem.
Right, exactly. And that's a hard thing for kids to do because they're often confronted with then the parent trying to solve the problem. And so then they're like, I don't want to tell them anything. And so it's really kind of doing both at the same time and then creating this new dance for parents and kids to do instead of an old dance of, I'm either not going to tell my parent anything because they won't understand or they're just going to try to fix it, or I'll tell my parents stuff and then get really upset when they try to fix it. Yeah. Neither of those outcomes is good. And so we're trying to change that dance.
Yeah, that really inspires me because I often say that my favorite skill and from my point of view, the most life-changing skill is validation. And I think that this really illustrates what you're saying in sense of, validation doesn't really solves problems, right?
Right.
It's not about solving it. It's about being able to say it and being able to listen to it, and sometimes to say something that is really caring and really, really good for the other party, right?
Exactly.
Yeah. Okay.
Exactly.
Thank you. Okay, so, I hope that there are some patients, some clients listening to us, but I also hope that there are some therapists listening to us. And I'm wondering, how can therapists develop their professional skills if they want to get more into DBT, working with children, working with adolescents?
Right. Well, I would say that, in Poland, right, there is the Polish DBT Society.
Yes.
And I think that is the place for therapists to definitely go and ask what trainings are happening. You will have a level of expertise here. And a lot of times I think countries that are beginning to develop DBT feel like, we need to go to the outside experts. We need to go to the outside experts. And yes, of course, initially for that learning. And I would say, though, that in Poland, you will have some experts already. And being able to figure out kind of who those people are and to have them be recognized is clearly important. And so for therapists listening, please contact the Polish DBT Society because they're going to be the best people to actually direct you to what trainings they're offering, what trainings can be taken advantage of. I'm certainly, I will be coming back to Krakow in September to do a training on DBT with young children. And so certainly that will be taken advantage. And my goal, though, is to have some of the experts here learn how to do that training so that it can be more widely available. I would say for parents, there is Family Connections, which is a free program, widely available. It is being modified currently to be working with younger kids, and parents of younger children are still accepted into the Family Connections. We are doing some modifications just because the younger children have some unique needs than parents of younger children. And so I would say that's a definite resource. I think being able to start asking your provider, is there DBT available? I think parents have an amazing role in terms of influencing what therapies are going to be available in Poland. If parents start asking, it builds the request, and then that builds the push for therapists to learn how to do this. And then when therapists learn how to do this, it becomes more widely available.
Thank you so much. That is really inspiring, and we are looking forward to seeing you again in September and October. And this will be a great, great autumn for DBT and children and adolescents. Thank you so, so much.
No, thank you for having me.
Nie każdemu udaje się dotrzeć do końca odcinka.
Cieszymy się, że dopłynęliście tu razem z nami.
Jeśli uważasz, że to, co robimy, ma sens,
Możesz nas wesprzeć za pośrednictwem serwisu Patronite.
www.patronite.pl/kurs na DBT.
Wdzięcznie spożytkujemy każdą przekazaną nam wpłatę.
Stwórzmy razem ogólnopolską debetową społeczność.
Do usłyszenia w kolejnym odcinku.